Welcome to the Microdosing for Healing podcast. I'm your host, Casey Garrett, and together we'll be discovering and learning from inspiring voices of healers, medicine keepers, and visionaries. Every episode, we'll explore the world of health, vibrant wellness, and natural medicine for a new era of human society. Welcome to today's episode. All right. Welcome back to the podcast, everybody. Thanks for being here. So today was inspired, as many of you know who have been in our community for some time, in our microdosing program since 2020 and 2021, in almost every single group that we have ever held space for, we always have at least one person in that group that is hoping to taper off their pharmaceuticals, usually an antidepressant. Either they're planning for it, intending it, they're microdosing to support their tapering process. And this year, more than any other year, I am seeing droves of people that are coming for that intention. I'm also seeing something pretty remarkable in practice in that people who have been on long-term pharmaceuticals suddenly feel like their body is literally rejecting them. They're like, I've taken this medication for years. They're just completely not working anymore, or my body is getting like physically repelling them and they're just really need to come off and compelled to come off. So then comes, we support them with microdosing practice, but in terms of their tapering process, that's a whole other can of worms. And so we love to work with professionals collaboratively that can help you dial in a tapering plan for yourself while we're supporting and holding space for your earth medicine process. So I'm super excited to bring you Dr. DeLon Canterbury today, who is an expert in deprescribing. He is leading a deprescribing movement across the United States. He's the founder of Geriatrics and very passionate about the subject. So we're going to dive in and dish on all things deprescribing. This is an episode I think you're going to want to save and bookmark and come back to, because I think all of us over time, if it doesn't impact us, we all have someone we love in our lives who is working through this and will be coming off some pharmaceuticals in the coming years. So DeLon, thank you so much for being here.
Yeah, absolutely. It's such a pleasure to be here and to share the journey of deprescribing and how I feel it's a necessary convo for people of all ages. So thanks for having me on.
Absolutely. I would love, if you will, take us back, because I know your journey was inspired by your grandmother, I believe, right? So what was her name?
Her name was Mildred. Yeah, Granny
Sweet.
Mildred.
Sweet. Mm-hmm. Yeah. Can you take us back and share her story and how she, her process inspired you?
Mm-hmm. Yes, absolutely. So while I was finishing up Emory University in Atlanta, my parents had to make the tough decision to move our granny from New York, from an assisted living facility, down to Atlanta in our childhood home. It got to the point where the community could no longer handle her behaviors as related to her dementia. So my mom was a teacher and my dad's an accountant, and they decided to bring her home. And, this is while they're still raising 3 kids. I'm in college, and my 2 other siblings are still in the home. They were thrust into caregiving at a pretty young age, and now, unfortunately, had to see firsthand how dementia can play a role, and unfortunately saw her get worse with everything that they were giving her, prescription-wise and healthcare-wise. And it took a couple of months for us to realize, from my grandmother, who was wandering, trying to escape the home, irritable, angry. It was at a refill at a Rite Aid where my mom was complaining about my grandmother getting worse. And the pharmacist took the time to pause, stop, and assess the entire med list, and discovered that there was one prescription that she thought was the culprit for her decline. And it was a medication that has an FDA black box warning stating, do not use in this population. It can increase the risk of death. Why are we giving a medication that can increase the risk of death? But that pharmacist was the one who advocated for what we call deprescribing, the safe tapering of meds that might be harmful. She called the doctor up. They came up with a plan, and lo and behold, in 2 weeks, Granny was way better and back to a normal, mild, cognitive impaired self, and was able to thankfully live to see another beautiful 8 years of life, and dying at the age of 90 years old on my last day of pharmacy school. Yeah. So that woman saved our granny's life, and it inspired me, but also infuriated me because why are we waiting for a train wreck to happen? This could have easily gone on for a few more months and she would have had some horrible thing happen. But why are we waiting? And why aren't we using people like pharmacists in a way to become deprescribing champions? We don't think every medicine is appropriate after a while, especially as we're aging. So we need to have healthy conversations on when to stop and taper them safely.
Beautiful. Thank you. Let's start with someone who is in the situation, right? Like, say someone is on some pharmaceutical medications and they want to taper. They're coming to you for guidance. Can you kind of take us through a typical case study of how you approach the deprescribing process?
Sure. So, first and foremost, we want to know what is considered inappropriate medication use and appropriate. So as we age, our bodies simply change. And we've been on meds probably for 10, 20 plus years at this point. We hit our 60s. So we start looking to see, one, do we have an accurate medication list? And this includes the dose, the time, how you're using it, as well as any prescription medication or over-the-counter medications, any vitamins, any supplements you might be taking. We want to know all of those things, any medicated shampoos and lotions, whatever. We want to know what all is coming into play because they all may interact and can be a part of the picture. So yes, your herbals matter, your natural supplements completely matter. We have to know. So we need to know what the accurate list is. And secondly, I like to talk to the patient or the caregiver directly and ask, hey, is this medication helping you? Do you even know what this medication is for? And why is it on board? A lot of people don't really know why they're taking some things or can really explain the need. So that also gives me context of, was this something that was meant for an acute issue, or was this meant to be a lifelong issue? And that leads to the next point, which is, what is the timeline for all these meds? Every med to me has an expiration. So is this a medicine that you need to have forever? Most of the times, no. Is this a medication that's helping extend your life or improve your quality of life? If it hits those two questions, then maybe we'll keep it on. But it's essentially a game of risks and benefits, pros and cons of each thing that you're taking, and assessing from a clinical aging friendly standpoint if their evidence supports continued use. And if it does, great. But if it doesn't, that's where we start talking about what deprescribing may look like and how we consider tapering the medication and how do we preempt potential side effects or withdrawals as we deprescribe. So to me, it's more than just looking at a list and saying you don't need this. We have to kind of understand what the patient's attachment is to the medication, to the health condition. Is it a fear? Is it what the patient even wants? Is it something that they're psychologically attached to because it's a part of their identity? You have to kind of unearth some of these social and cultural beliefs around taking a med. And so we don't want to, tarnish anyone's autonomy. We want to give people the right to choose. It's not just, I said this because I'm Dr. DeLon. It's, is this even appropriate for what matters to you right now?
Mm-hmm. Thank you. Far and away, the number one presentation we've seen is people who specifically want to taper off antidepressants. So I'd love to focus on that for a minute if we can, particularly SSRIs. And I have heard and seen so much misinformation. I've seen so much poor guidance in this regard. And so I'd love for you to speak to specifically SSRI tapering. If someone's coming to you and say they have been on an SSRI for more than 2 years, kind of what is your suggestion they set in terms of a benchmark, in terms of expectations, time, the tapering process, what that actually looks like?
Yeah. Yeah. People have found value in SSRIs. I'm not going to pretend as if it hasn't done wonders for a good bit of people. Um, but I agree. I think everything has a timeline. So if someone's ready to come off, the first thing I want to know is indeed how long have they been on it? How much has it helped? What are some of the behavioral changes you've made to maintain your current affect? Are you engaged? Are you no longer depressed or anxious? Are you staying active and working out? Are you talking to people? Do you have a social network? Do you have engagement? Do you have a role? So I want to see what you're doing in your day to day that could, essentially preempt any potential relapses, right, to your depression. So first, we got to see how controlled you are. So if we're assuming someone is well controlled and things are good, then yeah, we can have that healthy conversation on how we can consider tapering. So uh, most people are going to be on one or two classes of medications. They're going to be on an SSRI or an SNRI. SSRIs are selective serotonin reuptake inhibitors, and the other one is selective norepinephrine reuptake inhibitors. They have the same effect in a way in terms of mood management, but they work a little differently. So your typical examples of SSRIs may be your Zoloft, your sertraline, um, your fluoxetine, and then SNRIs. There's mainly like two or three. There's Cymbalta and Effexor. They both have different approaches on how you would consider tapering. So it gets very tricky when we start talking about SNRIs. Those medications can be very difficult to come off. I find it to be harder than the SSRI class. Reason being, it's your body just becomes extremely sensitive to any change when we start tapering. Um, and people can experience brain fog, brain zaps, electric kind of shooting, and really debilitating withdrawal symptoms. Um, so much so that people end up opening up the capsules and trying to find ways to microdose. It's really tricky, and unfortunately, the literature, if you want to call it literature, there is stuff out there, but it's not being used in clinical practice. So doctors are inadvertently just saying, well, let's just half it for 2 weeks and then half it for another week, 2 weeks, or let's have it for a month. And it's like, that's too aggressive. That's not how the brain chemistry works. You've built up years of dependence on a pathway through a medicine. So you don't just jam up all the works and it's going to just lead your patient into worse outcomes and potential harms. Nobody wants that. So there is a bit of a fine art in understanding the pharmacology, the receptor occupancy. You have to understand when we're getting into the weeds of this, especially been on this forever, you're going to end up having to do microdosing to get to this level of steady state. And this will be done over months. This is not going to be done over 1 or 2 months. This needs to be done over a long period of time. And usually the longer the taper, the less likely we'll see some of those debilitating side effects.
Thank you. Super helpful. I've seen this play out what DeLon just spoke to so often with the range in coming off of the different medications. I'm always so curious from the perspective of prescribers when some medications are so devastatingly difficult to come off. Why are some chosen versus another, right? And sometimes I think patients don't know they have capacity and right to ask, of the medications that you're prescribing to me, which ones are easier to come off at some
Mm,
point than others. Yeah.
mhm,
So thank you for speaking to the difference in the classes.
mhm,
Can you also share a little bit? One of the things that I have learned from witnessing so many people is when they're tapering off, especially off of antidepressants, they seem to do well at the beginning of the taper, but there's this lag time that happens. And so they'll do
mhm,
really well for the first few weeks. And then there seems to be a dip that happens like in week 4 and week 5 that we come to expect and predict now. And it's much easier to manage it if you know it's going to happen. You can kind of build lifestyle things and practices around to support yourself if you
mhm.
know you're going to go through a valley. But can you speak to that from your a pharmacist perspective and biochemistry perspective? Why is that lag time and delay happening?
Sure. Well, first and foremost, right, when you start a medication, we're often told, hey, this is going to take 4 to 6 weeks to see maybe a benefit or change in something. And then it'll take 3 months for you to actually fully assess if it's doing anything. And the same kind of applies to deprescribing. But also, this applies to some of the pharmacology behind how receptors work, how sensitivities work, how essentially as your body is used to something, it's going to end up kind of down regulating receptors for it to work on. And when you have too much of your serotonin and norepinephrine and running around, the body's like, okay, let's slow down. We've got too much. So if the body's always trying to reach this steady state, it's always trying to find peace. So when you throw off a bit of chemistry here, even if it's just a little bit, it's still a little bit of a shock to the system, which is why we do it as delicately as possible. In the beginning, as you're kind of making a change from, say, I don't know, let's say 10 to 9 milligrams, right? You're still, for the most part, hitting most of the receptor occupancy. So let's say that 10 is 100%, and let's say 9 is, I don't know, 95, right? You're still kind of in that state of kind of being covered. It's not going to be as deleterious as a jump from 100 to 50. But when we start hitting that halfway point in the tapering process, i.e., 5 milligrams, your body becomes more sensitive to the changes because there's these, again, trying to find a steady state. 190% occupancy, cool, but 80 to 50 and 60, you're going to start seeing differences that are more pronounced because now we're actually seeing a difference in how much is in the blood, how much is hitting those sites of action. And now your body is trying to, okay, well, I don't have as much as I used to, so maybe I need to make more or upregulate more of my receptor sites to work on. So this is always this game of kind of cat and mouse. And that's why when we start hitting these lower levels of receptor occupancy, and this gets very much in the weeds when we talk about hyperbolic tapering, um, you have to be slower. You have to move slower in your titrations because of those changes, because a smaller jump will have, or decrease, will have a more pronounced effect in how the drug is working. And yeah, in the beginning, it's like, cool, but think of things as a curve. And once you hit this little S curve, then it's like, oh, if I move just a little bit, you could put someone in a withdrawal. So that's really the science behind why we have to get slower as we get to the lower stages of the tapering process. And this is detailed and very much so in the Maudsley manual for deprescribing of antidepressants.
Excellent. Thank you so much. It's so vital and so helpful for people to know that going in because it's so counterintuitive sometimes. I've seen a lot of people, especially people who try to taper on their own, they say that they started off fine and they were surprised because they went from 200 to 100 and then 100 to 50 and they thought that was a big jump and so they're kind of like I got a little cocky and I thought oh I can just go cold turkey from here because I'm handling this really well, not
Yeah,
realizing exactly to your point it's actually the end of the taper that's more challenging than the beginning of the taper. So
correct.
that's super, super helpful to know. And you can kind of go in with that mindset. Super helpful. The other thing I've really witnessed and learned is there's a huge difference not just based on how much of the medication they're taking, but how long they have been on it is
Mm-hmm.
far more relevant to their tapering experience. So sometimes
Mm-hmm.
I'll have people come in and go, "Oh, it's no big deal. I only take this teeny tiny tiny bit of Lexapro." But then when I ask them, "Well, how long have you been doing that?" 26 years. Like,
Wow.
right?
Wow.
So that's a huge difference, and it's actually much easier to taper off of a very, very high dose of Lexapro that you've only been on for 4 months. That's going to be a very
Correct.
different experience. So, from your perspective,
Totally.
can you share why that happens?
It still comes down to the chemistry, right? It's how much time has the body been given to adjust to the use of a medication. The body is always trying to keep that steady state going. So if you just started the process of a medication, you may not have even hit that steady state point that 26 years of taking something would. So again, they're all playing a role. And as your body gets used to it, it's going to reach that middle ground. If it's been very early in the initiation process, you'll see often that's why people sometimes switch at the 3 month mark with a probably a more aggressive taper because you haven't really hit the steady state of the drug to work to its fullest potential. So when we have a shorter timeline, that can also give a little wiggle room for more aggressive tapering because you just haven't hit that sweet spot yet. With older adults, it's all very sensitive, so you still need to be a bit more conservative with medication changes. But you know, there's a little more wiggle room if we haven't hit that steady state yet.
Excellent. And is it true that once you stop taking the medication, you're still actually tapering off the medication well beyond the last
Mm-hmm.
dose you take of that? Can you share a little bit about that?
A lot of this will have to deal with pharmacology in terms of the pharmacokinetics and pharmacodynamics of a drug. And what that means is how a medication is cleared, eliminated, absorbed, and distributed across the body. All of that can vary from liver function, kidney function, how much fat's in your body. And as we age, we kind of have a diminishing effect on all of those. We kind of lose some of those. Um, but ultimately, it comes down to something we call the half life, or the time it takes for a medication to be halved as it's being cleared from your body. So, how long does it take for a 100 milligram dose to become 50 milligrams in your body? What amount of time is that? And that amount of time is considered a half life. When we're looking at medications, every medication has a half life, depending on a number of factors. But based on those half lives and how the drugs work, for instance, if you have a medication that has a very long half life, for instance, fluoxetine has a very long half life. It could be 26 hours, it could be 3 days, depending on your body's chemistry. So if you were to stop it, yes, the first 2, 3 days, you may not feel much of a difference because you haven't hit half of the dose internally yet. Whereas short acting meds, I don't know, whichever ones that are only a couple hours long, for instance, a shorter acting medication would be paroxetine. I hate that drug in older adults. So I don't like it. Paxil or paroxetine, that half life is, I don't know, 4 or 6 hours or something. So if you take it in the morning, by nighttime, you've already got like 2 or 3 half lives from your starting point, right? At 100 mgs in the morning, you're already hitting half a dose at noon, and then you're hitting another half of the dose by afternoon. By nighttime, you're 3 half lives out. So you're going to start feeling the withdrawal effects very quickly. And that's why knowing the half life, the pharmacology of the patient, the drug, the type of drug we're talking about, whether the drug has an active ingredient or a prodrug, those things affect the chemistry and timing, and hence affects how we taper. It affects how long we can taper. Yes, some meds you can kind of self taper off, but some, you have to be a bit more judicious in your approach.
Mm, thank you. Super helpful. I'd love to inquire about polypharmacy. Sometimes I'll do intake sessions with clients and they'll bring their pharmacy to the Zoom call. Right? And there's like this bottles and bottles and bottles of medications in front of them. When you are confronted with someone who is on, say, 6, 8, 12 different medications, and they want to deprescribe as many of them as possible, just how do you even begin to approach that process?
Yeah, a lot of our patients are in the boat and they are usually on 15 to 25 plus meds. And because we're dealing primarily with older adults, we like to focus the discussion to what matters most to the family and the patient. Do you want to walk more around the house? Do you want to spend more time with your grandbaby? Is there a certain goal you're looking to achieve? You want to dance again? You want to go back singing? I try to personalize it to what makes them tick. And once we know that, we can formulate a plan that aligns with their goals and what clinically might be competing with those goals. So when we're working as a pharmacist, we're looking to see, one, are the meds aging friendly? We're looking at the types of medication, the class of medication. Of course, the number of medication matters. So we define polypharmacy as the use of 5 or more medications. That doesn't mean if you're on 6, 7 or more that they're all bad or inappropriate. It just is a soft marker of we need to look at things a little bit more closely because as we're older, there's just the medications aren't exactly doing what all the things that we think they're doing. And the evidence tells us the longer your med lists, the higher the risk of harm associated with it, with drug interactions, side effects, falls, cognitive impairment, you name it. So knowing all that, we have to kind of sift out what's considered good polypharmacy, bad polypharmacy. But beyond just that, we're looking to see if it's aging friendly. Are the meds actually appropriate for a 70-year-old, 80-year-old today? And they may have been cool when they were 40, but now is it doing more harm than good? I think a classic example is baby aspirin. Everyone thought baby aspirin was cool. Everyone was like, this is good for our heart. That's what we were told back in the 40s, who knows when. But now evidence tells us that people don't need to use baby aspirin if they've never had a cardiovascular event. If you've never had a heart attack, if you've never had a stroke, and I guess no blood thinning event or blood clots or whatever, but if you've never had anything like that happen and you're just taking baby aspirin because you heard it, then the evidence tells us there's a more risk of harm than benefit. So you don't need it. And this is recent as of the last 4 years in practice. So there's new information. And so a lot of it's going to come down to how do we educate our client or patient on, hey, you've been doing this for so long. Your blood pressure looks great. Do you still need 4 blood pressure meds? Maybe not. Maybe we could stop 1 or 2. We look at your blood pressure meds later on, your readings. And if they're still normal, then great. We had a win. There's 2 less meds you don't need to take. I think that's the approach we should have for all medications. But I find patients are sometimes afraid to have that discussion. So that's why we're adamant about teaching people that deprescribing isn't a bad word. It's literally just advocating for yourself and getting critical questions answered on the timeline and necessity of benefit.
Thank you so much. I'd love for you to reflect on, you've been doing this for some time now, and one of the kind of first in this space, if you will, doing deprescribing work. I relate and resonate with that place, but now the tide is turning dramatically. And I think more and more people have access to more and more information, and they're saying, wait a minute, a lot of the effectiveness of antidepressant studies were actually the ones that said they weren't effective were buried, it turns out. And now that's coming to light. There's more and more studies showing that, drugs like gabapentin are tied to dementia. And people are having much more access to information. And so I think they're driving it. At this point, it's not the science top down. I think it's people are coming and going, hey, what about this microdosing? mushroom stuff. I'm hearing that it works, or hey,
Mhm.
I can deprescribe off my medicine. So I'd love for you to zoom out a little bit and speak to what's gotten us here. I was listening to a podcast you were speaking to, and you identified three things: the silos of the current industry, that we operate in silos. The other
Mhm.
one was ego,
Mhm.
an unwillingness to be wrong and
Mhm.
evolve. And then the last one was greed, was human greed.
Yeah,
So I'd love to just give you the floor to reflect on what you have seen, where we've been, and kind of hopefully where we're going.
sure. Yeah, we are up against a pretty large behemoth of the pharmaceutical industry, which has done wonders for humanity. I will not take away the fact that we've lived longer and better because of certain medications. But there's always room for Eastern and Western medicine. And there's also always room for integrative medicine and holistic medicine. We can have room to play with all players in the room, but one doesn't like the others being around, right? So when I spoke to those points about some of the barriers to what's led to over prescribing or over dependence on our medical system and polypharmacy, yeah, that those are just a couple. There's so many more barriers. First of all, we've got this again systemic issue where we have this essentially a fee for service model that's trying to shift to value based care, but it's a model where the more people you see, the more money you make. And that's unfortunately how healthcare kind of works, is that's how they get reimbursed, right? And we are shifting from that, but that's been the payer model for a while. We have schooling and education where we're only taught to treat in Western medicine through prescriptions. We're not taught about holistic, lifestyle, nutritional. We really generally poo-poo that, although it's important and the data tells us it's important. But to clinically act on it and trust your patient and make those behavioral changes is a deeper societal issue that a doctor can't really fix in a 20-minute consult. It's just hard. Um, so that's what I mean by silos is really we need a nutritionist to be seeing them first. We need a lifestyle coach to be seeing them first. We need someone to assess their depression first. We need someone to make sure they got healthy meals, transportation, all the basic necessities we need to live are put into question when we've got inflation and all these other geopolitical issues affecting your layperson who can barely afford to eat. So you expect your patient to be the doctor of their lives? No, it's very hard to do this stuff. So we've got a pharmaceutical industry that has the most money in the world that's going to constantly advertise the next new thing that you need to have. It's targeted for you to think you're missing out on something. So America likes things quick and fast and dirty. We don't want anything hard. So we're not going to take the hard way and do the things. We're going to just take the pill. So we're feeding into that. And yeah, I mean, again, deprescribing, I didn't even know what that meant until I became an aging friendly pharmacist. And I've been a pharmacist since 2014. So what's that say? I mean, I've been in the game, 13 years or so. So, it's there are many factors. We also don't use um, pharmacists to the top of our license. We're seen as dispensers instead of consultants. Hence, me starting this company to change that narrative. And yeah, there's a lot of ego in medicine. People don't like to be wrong. And I think that's taught in the schools. It's a very cutthroat environment to be perfect. And it doesn't exist, but yet that's what's taught and indoctrinated to never be wrong. So that loses the humility in medicine and learning from each other. And unfortunately, now that leads to egos and titles and names and stuff and in your signature that affects your outcomes. And it's a shame. And because the patient's the one who ends up footing the bill either way. So that's why we encourage coaching our clients to never take no and take ownership of their health. Don't just assume that someone's looking behind the scenes for your well-being. Most often they don't have time, and they won't unless you demand it. So part of this process is understanding what we're up against. It may seem bleak, but people are awakening, and a lot of people, I'm just seeing it online. And I mean, everyone's fed up with taking all these meds. Everyone's fed up with the industry getting richer and it's not leading to better health outcomes. Everyone's upset with paying more in taxes and not getting what they deserve out of their healthcare. It's all expensive. That's why we're leaving the country. That's why we're going to find medical services in Mexico and Dominican Republic and what have you. So we know we have a problem. I don't foresee it being fixed anytime soon. We're not shifting to a universal payer system anytime soon. So knowing that these are the barriers, now you got to know how to play the game. So the game is you need a team of experts to help navigate this with you. You have to explore what resources are in your community that could be freely available, freely accessible, because there's likely someone who could probably solve the problem you're facing. That's why aging to me is so difficult, because people don't know this stuff. You're not taught this stuff until you're thrown into caregiving, and now you got to figure out a place for your mom to live. Now you got to hire a home care company to watch while you're at work to pay for them. Now you're calling out of work because there was an emergency, there was a fall. So the caregiver is pretty much every American paying for all this because of a broken healthcare system. So what do we do now to preempt that harm? You ask the questions, you get the resources, you be vulnerable in that you need help, because I can guarantee you this: doctors don't make the best caregivers either. We don't know this stuff. The health system's complex. So you got to really speak loud and proud for what you're looking for. But I have faith because, again, people are waking up. Everyone's looking into alternative approaches. We've got new research diving into alternative therapies, holistic care, like you've mentioned, mushrooms or microdose psilocybin, DMT. We've got other avenues that we're looking at for neuroplasticity. The research is great, and that research is what's going to lead to future changes. Even decriminalizing marijuana has been helpful, and at least in some states, for research. So again, I think people are fed up with another pill, yet I'm seeing more providers go into holistics and integrative approaches, and pharmacists and nurses and doctors as well. They're leaving healthcare and starting their own practice or doing primary care services using subscription models, which we also coach pharmacists and others how to integrate into their models. So things are changing. And unfortunately, the stuff that you need the most, you're probably going to pay out of pocket for. And that's how it is. You got to pay rent, you got to pay bills. But it impacts our older adults who have the least revenue out of all of us. And so we have to think it differently about how we create these blue zones so our older adults have the resources and have the support. And more importantly, we train our providers to think in this manner, to hit this head on. But it's, I'm hopeful, but hey, it's not an easy game.
Thank you. So valuable. I know for myself, in studying these topics, a few things I learned that were kind of painful to learn, but I think it's so important for people to see the truth, behind the curtain now of knowing how much. I mean, we know that the pharmaceutical companies are for-profit companies, and so they have a vested interest in not making things available that actually heal people, right? But I was really surprised to learn how much the American Medical Association and AMA lobby has done to suppress other healing professions over the last decades. I was also surprised to learn that the United States is one of the few, if not only, countries that allows pharmaceuticals to be marketed commercially on television. And also learning that the United States is the only country, one of the few modern countries that does not cover deprescribing by insurance. And so it's like, we have to see and learn these things. And I think that too is kind of these big truths that are coming to light is all of these entities that we thought were looking out for us and that we thought we could trust, it's driving us back to self-trust and
Hmm.
self-knowing and asking
Yeah.
more questions. So
Hmm.
thank you for
Yeah.
the work you're doing. Yeah, yeah. Pivoting a little bit into you brought up the business aspect of things. Lots of times, as you know, like pharmacists and doctors spend many years in academia. You're not trained in business, right? You're not trained to
Hmm.
be entrepreneurs. And a lot of times
Hmm.
these are very different skill sets to adopt. But more and more I'm seeing, I know every year we're seeing more and more doctors and clinicians, pharmacists and nurses coming to our microdosing programs and becoming entrepreneurs, like setting up concierge cash pay practices. So as someone who has done that, can you share a little bit for all the listeners who might be clinicians that are thinking about taking the leap to become an entrepreneur,
Hmm.
what that path has been like for you?
Sure. It is definitely not for everyone, as people like to say. It's not. It's just not. Um, I would say um, the part of this process that's going to be your biggest challenge is reframing your mindset about what success looks like. We oftentimes focus on numbers and like doing things fast, and um, what you learned in school is not going to help you here. It's just not. It's take that, just see this as a whole different game and a whole different mindset. And you have to face things as a, what am I going to learn from this mentality, whether it's the outcome you want or not. If it's an outcome you didn't want, what was the lesson that you need to learn from that? And when you get out of this mindset of, well, I didn't hit my goal, so I'm a failure, the sooner you get out of that, the faster you'll thrive and the faster you'll move when you ask for help and ask for support and let vulnerability and humility lead you to the next phase. Because the more you think you know it all, the slower your progress will be. And so you have to leave the ego behind, leave your credentials behind, and come in with complete humility to, I don't know what the hell I'm doing. I need help and I'm going to ask for help. So that mindset will take you way further than trying to do it all your own and suffer in silence.
Oh, thank you. Beautifully said. Beautifully said. And I just probably not a coincidence yesterday, just coincidentally, I had two interactions with doctors yesterday, and both of them were so strapped for time that one made a simple error just because he was so overwhelmed and strapped for time. It was no big deal,
Mm,
but he was so apologetic and so hard on himself that he had made this tiny, very fixable error. And the
mm,
other one was like literally running down the hall to his next patient, still giving me more advice and guidance in the time strapped of the 7 minutes that was allocated to me. And one of the
mm,
things I've heard you share before, it's really not the doctors. Like the doctors are being forced to practice medicine in a way that was not at all their intention for getting
mm,
into this work. So I would love to share, especially what I was left with yesterday in these two experiences with my doctors was I left with so much compassion and I just
mm,
wanted to support them because so many doctors are going to be opting to move to cash pay concierge models because they want to support their clients and they want to
mm,
actually heal and do medicine. Um, Again, but it's going to be, I think, as you said, it's a steep learning curve to learn how to be an entrepreneur. And so I just like give some love to your doctors and your clinicians and give them
mm,
space and support as they're kind of learning how to be business people too.
mm.
Yeah.
Yeah. Yeah. Yeah. It's not really in our DNA, you know? So, yeah, give yourself grace and, don't beat yourself up.
100%. So if you have a clinician, doctor, pharmacist, prescriber who would love to learn more about specific deprescribing, this is not readily available. You don't necessarily learn this in medical school. Do you coach and mentor and train others to do what you do?
Yes, we created a coaching program called the Deprescribing Accelerator. It is intended to teach, coach, even provide some CEs for our pharmacists, our nurses, our doctors, prescribers, NPs, PAs, all the above. It's meant to be interdisciplinary because we all can become advocates together. But yes, we coach you on patient cases. We teach you how to think from an aging friendly perspective when it comes to patient notes and patient care. We give you the toolkits on what I use for prescribing, electronic tools. And then, of course, we give you the business side of it. How do you create a business doing this? How do you package your services? How do you find your ideal client? And how do you come up with your service that's value based and servant led? And when you have those niches, we then marry your passion with that. If this is something that moves you, we work with people that are passionate and care about our population. So this isn't a money grab. This is literally the business side of prescribing that I feel we often don't talk about. And pharmacists and clinicians all know the value of it. So let's get paid our worth.
Amazing. Thank you for the beautiful work you're doing. I have a hunch you're going to get really busy in the coming years,
Oh, yeah.
even busier than you are now. So, yeah, beautiful. Thank you for your leadership in the space. If folks, we're going to drop all of your links into the show notes for those that are hiking and listening. Can you share audio-wise where to find you? Are you on the socials, and share your website link?
Yeah, you can find us at geriatrix.org, GERIATRX. We are on all social media, so IG, YouTube. We've got a channel where we actually provide the red pill versus blue pill, where we teach people some of the tricks we've used in business. We're also on LinkedIn, so you can search for Geriatrix or my name, DeLon Canterbury, and you'll find me pretty easily. And then, of course, we do have a TEDx talk. So check out our TEDx talk on the hidden power of deprescribing now on YouTube.
Fantastic. Thanks so much for joining me today. I appreciate you.
My pleasure. Thanks for having me.
Absolutely. All right. Thanks so much for listening, everybody. We'll see you back in just a couple weeks. Have a great day. Thank you for listening to the Microdosing for Healing podcast. Ready to take the next step? Please visit us online at microdosingforhealing.com. There you'll find lots of information about our global community, professional training programs, and upcoming immersions. See you there.